So what we are doing today is look at Dr. Seheults, a pulmonologist and care doctor. He has a website called MEDCRAM, which I use all through school to basically supplement, pretty much provide my education. Amazing work on simplify complex concepts. And since he is a pulmonologist at coronavirus COVID, today I saw that he recently had a video on vitamin D and its effects on treating COVID-19 as well as preventing it. And I think there's some interesting things here that I didn't know and didn't learn during my education that I think are going to be really interesting. This is going to include some of his teaching methods. Some of it may be a little too complex, so I'm going to take notes while I watch this and kind of simplify anything that I think may need to be simplified further. This is intended for people that are interested in science background, not necessarily that have one, but somebody that wants to learn about it. It'll be easier for them. For those who don't have a science background, I'll try to simplify it as much as possible and clarify these. So here is the video. I left in the description. I left his link so you can find all his. We'll start it.
Dr. Seheult, you've advocated for vitamin D as a potential way to prevent COVID-19 infections, to prevent severe COVID-19 infections. You've talked about this for a few months now. And over the past several months, the evidence continues to grow. There's more and more publications in peer-reviewed medical journals about the possible connection between vitamin D and COVID-19. So you've put together a presentation for us. Tell us about what your presentation is all about.
Yeah, thanks, Kyle. So we've been talking about vitamin D as a potential therapeutic agent for COVID-19 since March. And since that time, a lot of other people have become involved in looking at that agent as well. A number of research studies have been done. And the purpose of this is to sort of look at the evolution and the thinking of the use of vitamin D in COVID-19. So what we do is we look back even before COVID-19 and what was the evidence for vitamin D in acute chest infections, for instance, influenza, and what was the data there. And then we look at the epidemiological evidence for vitamin D as a therapeutic agent in COVID-19, and then finally moving along to actual cases, hospitalizations, and then we build up with that hierarchy of evidence with vitamin D and COVID-19 to randomize placebo-controlled trials, which of course are the gold standard for therapeutics.
Okay, so let's talk about vitamin D. The first thing you've got to understand is that vitamin D is not just a vitamin. Vitamin D is actually a hormone. And if you notice here by the structure, you'll see that it is a steroid hormone, which means it can go into the nucleus. It can go through membranes and make effective changes.
So right there, he's saying vitamin D is actually not a vitamin. So what a vitamin, he's going to explain it later on, but I figure we just do that now. So when you hear it a second time, it'll more to you. Vitamin stands for vital amine, and amine is just a chemistry terminology molecule that has a nitrogen group. It's not important, but it means it's a vital amine. And what vital means is our body doesn't make it. It is vital that we get it from outside sources. So vitamin D was thought to be a vitamin. It is essential. We need it for not only calcium, which you've probably heard of, but we need it for much other things. And one thing I did not know was vitamin D is a steroid. Or it looks like a steroid right here at this group right here. If you look at any of cholesterol molecule or any of the steroids like estrogen or testosterone, they'll share this common thing. And why steroids are important is steroids affect the way our DNA is read. It controls the management of DNA and all proteins expressed. So a steroid can slip across the skin into cells without having a receptor. Its receptor is actually inside the cell. It binds, as you can see in this picture right here, it'll come into the cell, bind to the steroid receptor, and then go into the nucleus or brain center of the cell where the DNA is and start copying protein. So it really tells our cells how to live, and vitamin D really has a lot bigger role than what we originally thought or what I've learned in its importance in calcium metabolism. It has a lot of roles by affecting our DNA. So.
And specifically, the vitamin D receptor is a member of this nuclear receptor steroid hormone superfamily. And so as you can see here, we have vitamin D going through the membrane and affecting a binding to the receptor, and then it actually goes into the nucleus where it can affect transcriptional change. This is really important. So this is not just some vitamin that you need to supplement with.
Real fast. Transcription is basically reading the gene or the recipe that your DNA has. When you hear transcription, it's reading it. Translation is making it. So it reads the recipe or copies the recipe, and then when it reads it and makes the food or your proteins, then that's translation.
This is actually a hormone that changes the way your cells in the body actually behave.
Is this idea unique to vitamin D, or does this happen with other vitamins? And in addition to that, what are some of the main differences between a vitamin and a hormone?
Good question. So, a vitamin is actually a shortened version of a vital amine. Vital meaning you need it to live, and an amine is a type of chemical compound. Vitamin D is not even an amine. Of course, it's vital, but it's not as if you need a certain amount of this substance to just keep the body going and doing what it needs to do. No, I mean, vitamin D is so much more complex than that. We used to think that vitamin D was just involved in calcium regulation, and that is certainly true. There's no question about that. But vitamin D is so much more than that. It's a fat-soluble vitamin, which means it can pass through membranes without any problem. It doesn't need to be regulated. It can bind with the receptor and go directly into the cellular portion of the nucleus, in fact, and actually cause or prevent transcription of RNA. And we've seen that there are vitamin D receptors in numerous cell types, including the cell types of the immune system. So in that sense, it is a hormone, but in another sense, you can only produce enough of this if you have enough sunlight, or if you're taking this in a dietary supplement form. You can't make this without sunlight or getting a dietary form. So in that sense, it is vital that you have it, and in the loose sense, it is a vitamin. So to get to your second question about hormones and vitamins, hormones are something that the body uses to signal and to make effect changes throughout the body. For instance, insulin is a hormone. Cortisol is a hormone. These things circulate through the body, and they have different effects on different target tissues. Vitamins are more along the lines of...
So to be a hormone, define you're released from one part of the body, travel in the bloodstream, and have an effect another place in the body. It can be a millimeter, or it can be the whole length of your body. But it has to leave one place, go in the blood, and then end up somewhere else to be defined as a hormone. No matter what it is or what it's made of, that it acts that way. So it can be a neurotransmitter. So like dopamine, epinephrine, norepinephrine, they act as neurotransmitters, but they also act as hormones in the blood. So adrenaline, norepinephrine for vasopressors. You guys all know testosterone.
Something that you need as a cofactor or something else to get something to work. And so in that sense, vitamin D is certainly a vitamin because your body needs it in order to live. But in another sense, it's so much more than just a vitamin.
So how do you get this vitamin D? Now, I know this looks a little complicated, but bear with me. The key that you need to understand is that it's the 1,25-dihydroxy vitamin D that's the active form. And it says here that it does come from the kidneys. But in fact, we now know that the rate-limiting step that puts that one hydroxyl group on is not just in the kidneys, it's also in the immune cells. And it can actually put that on and have effective change in your immune cells.
That's something I didn't know, was the immune cells.
Let's talk a little bit about how this happens. So there's basically two ways you can get vitamin D into your diet. You can either eat it through a supplementation, swallow it. You can take pills. It's also found in fish oil, certain types of mushrooms, egg yolks, and also red meat. Or the majority of people get vitamin D into their system from the sun. Why is that? Because ultraviolet B radiation penetrates down deep into the dermis, where this cholesterol derivative is converted into pre-vitamin D3 and then finally into vitamin D. Now that vitamin D3, after it's produced by the sun, goes to the liver and the 25-hydroxyl gets put onto it. This species here, the 25-hydroxy vitamin D, is what we actually measure in the blood. Whether you get it from diet or whether you get it from the sun, There's two ways of getting it, but this is how we can measure it. And that's how you're going to see it measured and reported in the rest of this presentation, is 25-hydroxy vitamin D. This is kind of like the storage product in your body. It's fat soluble. It is stored in the fat. Then when it's needed, it can either go to the immune system where it's converted into 125-dihydroxy vitamin D, which is the active form, or it can go to the kidney and it can be converted there to 125-dihydroxy vitamin D. Now, the one in the kidney is usually used for metabolism of calcium and phosphorus and things of that nature. But there's a whole nother area. And in fact, they found many vitamin D receptors in the leukocytes, or the white blood cells, your immune cells in the body. Now, the other thing you ought to know is that this 125-dihydroxy vitamin D, which is the active form, can be inactivated when they put a hydroxyl group, they being the 24-hydroxylase end.
I'm going to skip some of the biochemistry and the science because I'm not sure if I knew the immune system created the final step in activating vitamin D. The more I look at it, I want to say yes, but I think I'm just saying that because I didn't know that. I didn't know it today. I knew it before I forgot it. And this paper that's being referenced down here at the bottom is from 2017 and 2020, so it's definitely after I went through primary. What he talks to.
Living above the 35th parallel or living below the 35th parallel in the southern hemisphere, this can be a very significant issue. The 35th parallel, for those who don't know, sort of runs through the middle of the United States. Now, some have suggested this may be the reason why we see an increase in viral infections in the winter time, whether it's in the northern hemisphere or the southern hemisphere. Wintertime is when you're having less sun exposure.
But couldn't this also be explained? Couldn't the increase in viral infections also be explained by just people spending more time indoors, in close confinement, windows closed, potential for spread that way, among other potential confounding variables?
Yeah, it certainly is possible. One of the things that goes against that, though, Kyle, is that, for instance, in the United States, in the wintertime, in California, for instance, Southern California, it rarely gets cold enough that you have to be indoors. But we still see an increase in a spike in influenza during that time. What is certain, though, in California, and this is where the 35th parallel sort of runs right through Southern California, is studies have shown that if you live above the 35th parallel, you can't really get enough vitamin D just by sun exposure in the wintertime. So while it is possible that there could be confounders, we're seeing sunlight exposure correlating with the increase in infectious diseases. I would note, if you look at this graphic from the CDC in terms of statistics, we see that in just the very months where we have vitamin D deficiency is where we have spikes and increases in influenza.
So we've got good data that shows that a major cause of vitamin D deficiency is inadequate exposure to sunlight. Also have good data that we'll talk about that there is an association between vitamin D and the BMI, and that patients with kidney disease, just like we see in COVID-19, can lose vitamin D3 out of their system. We also have good data that for more than a century, vitamin D deficiency has been suggested to increase the susceptibility to infections. And when you look at the extreme vitamin D deficiencies, for instance, in children with nutritional rickets, they also had an increased risk of respiratory tract infections, or RTIs. And as we talked about, so this is certainly a public health issue that needs to
I don't really want to. So this is looking at vitamin D levels in percent of subjects, and being the total being 8,405%, 24% in Mexican American, vitamin D and race. So
different levels of vitamin D. Here's less than 10, here's 11 to 20, 21 to 30, and greater than 30. And these bars simply represent white is white, black is black, and the gray are Mexican Americans. This is a study that was done in the United States. And what you can see here in this observational study, at greater than 30, which would be considered to be adequate, the majority of that population is white. As we go down below 20 in this range, that the people that make up the majority of this population are disproportionately darker skinned people. So this is certainly a public health issue that needs to be addressed. Another thing that we've known about for some time, for about 20 years at least, is vitamin D and BMI. Of course, vitamin D is a fat-soluble vitamin. And as such, it's going to be stored in the fat. And so if you have a lot of adipose tissue or fat, then you're going to have a larger capacity to hold vitamin D, which means you're going to have less soluble vitamin D to be used.
So that's kind of confusing. There's 4 vitamins that store in the fat, and that means that you can actually overdose on these vitamins. Other ones that are stored in the water, which means they can be peed out. So these vitamins can't be peed out. That is A, B, vitamin D, what we're talking about, E, and K. Vitamin D is what we're talking about with calcium, immune system stuff. Vitamin A, retinoic acid, stuff that we think about with vision. Vitamin E, we think about with skin usually, and vitamin K, very important in our blood clotting. So if you know anybody that's on a blood thinner like Coumadin or warfarin, or if you've ever used rat poison, this one inhibits synthesis of vitamin K, causes you to. That's why we actually, or as blood thinner, strokes, heartbeats. So, but it's saying here, since it's stored in fat, the vitamin D would much rather be in your fat cells than it would be in your blood vessels. It doesn't want to be in the water, it wants to be in the fat. The more fat you are, the more your body's going to hold on to that vitamin D rather than having it in circulation where it can. Even though you have more total vitamin D, the availability of that is low.
This is a direct quote from this study. Because humans obtain most of their vitamin D requirement from exposure to sunlight, the greater than 50% decreased bioavailability of cutaneously synthesized vitamin D in the obese subjects could account for the consistent observation by us and others that obesity is associated with vitamin D deficiency. Oral vitamin D should be able to correct the vitamin D deficiency associated with obesity, but larger than usual doses may be required for very obese patients. Okay, so where are we right now with vitamin D supplementation? Currently, there's no international consensus. We know that supplementation of vitamin D can help in terms of fractures. Now, there are some studies that show that vitamin D may be associated with increased risk of myocardial infarction, but in actuality, those studies were related more to calcium supplementation with or without vitamin D. So not a direct association. The target for prevention of fractures is around 30 to 40 nanograms per milliliter, and that if you have levels greater than 150 nanograms per milliliter, that is associated with hypercalcemia.
When treating your own, if you need vitamin D supplementation, I know some people do it on their own. But this is something that you'd want to talk to with your doctor about. Make sure that your doctor knows, because I don't know these numbers. When it came to like vitamin D levels and studying it, I felt it was always something up, and I didn't want to pack my brain. Often am I going to? Now it's like there's a more important role for it. I think that was really important when he said that the oral vitamin D, when you take it orally, your body should use it as it's needed. Since it's stored in fat, it says that you may need a larger dose than normal if you are obese. That's due to the BMI. You may think you look fine, which is totally up to you. But when it comes to medicine, they're going by that BMI number, which makes us all feel bad, because even if we look good, it says we're overweight. So we're underweight or overweight, but it's basing it off that. So speak with your healthcare provider.
Yeah. So what do people say? There's some people that say you should take 4,000 international units or less. Some others say up to 10,000 international units. There's not really a consensus. There are some recommendations from the Endocrinology Society, and we will discuss those. Okay, so let's look at the evidence of vitamin D insufficiency and deficiency in mortality from studies that were done not on COVID, but prior to COVID, but still looking at respiratory diseases. So here's an interesting study that was done looking at about 10,000 patients in Germany with 50 to 70-year-olds. It was prospective, so that's definitely a positive for this study, but it was an observational study, so they weren't intervening here. And look at the years for follow-up, 15-year follow-up in these patients. So let's take a look and see what they did. They measured these patients in Germany and looked at their vitamin D levels. And you can see that here on the x-axis. So again, this is in nanomoles per liter. So you have to divide by 2.5 to get nanograms per milliliter. And generally, they made some cutoffs here. This was at 30, and this here was at 50. And so they said, if you're greater than 50, then that's good. If you're in the middle portion, that's 30 to 50 nanomoles per liter, then that's sort of in the middle. And then here, you've got less than 30. That's what they figured as deficient. And then they just followed them. They just watched them, and they see what they did. And they looked at the death certificates after 15 years in these patients that started to die, and they wanted to see what was it that they died from. And this is what they found. Those people that had vitamin D levels of greater than 50 had a better survival in terms of respiratory mortality than those that had less than 30. And of course, the 30 to 50 were somewhere in the middle.
And that percentage is falling within 98 to 100% of the 2% variation.
Definitely statistically significant in terms of vitamin D levels predicting respiratory mortality. In fact, from the study, they said statistically, after adjustment for sex, age, and season of blood draw, school education, smoking, BMI, physical activity, and fish consumption, 41% of the variability in respiratory mortality during this 15-year follow-up period was independently associated with 25-hydroxy vitamin D levels less than 50.
Wow, that's actually... So it said when accounting for every other bias, smoking, age, when you got your blood drawn, get all of that and make everybody the same there. One that stood out, died from respiratory issues, was the one that was low on vitamin D, lower than that 50, at far right. Less than that, 41% died from...
It's one thing to say that somebody with a specific
issues.
value has a likelihood of dying. It's quite another thing to say that number caused the patient to end up that. So in other words, there's a difference between association and causation. That's the first thing that you learn in medical school when you take epidemiology. So here is a great meta-analysis that's often cited, and you should keep an eye on. It was published in the British Medical Journal, and they did a meta-analysis. They did a meta-analysis of many, many different studies. They pulled them together to see whether or not vitamin D supplementation in non-COVID patients, these are patients that don't have COVID-19, these had regular respiratory diseases like the flu, and they wanted to see whether or not vitamin D supplementation improved mortality. And so they looked at vitamin D supplementation. They looked at about 25 randomized controlled trials. So these are very good quality subjects. And what they found was that vitamin D supplementation did reduce the risk of acute respiratory illnesses. Let's take a look at that data. So here you can see all of the different studies that...
So I'm going to take him, I'm going to believe what he says. I've enough of him, enough that I can trust what he's saying. But basically what he's saying... you guys weren't paying attention, is that vitamin D has this positive effect on your mortality or the well-being of your body and the life and death of your body, strictly related to respiratory issues. And that's like super interesting to call out, to actually do this study, which is a prospective study saying, we're going to take this group of people and we're going to just watch you for 15 years and see what happens to you. I mean, that's a long time to follow up to people. You might expect some not to come back and some to, but it seems like they did a really good job because they got statistically significant results. And the only thing about statistics, I really don't, because it's good. It means that you can trust the numbers, with give you a value, and if that value falls in with 0.5%, relevant number. And they were saying that people that had less than the 50 units of vitamin D, 25 hydroxylase, died directly related to. So even if you're not having a virus, it's causing some respiratory. So maybe I should start
to prevent seasonal influenza A in school children. And this was done about 10 years ago. There was 334 school children. Each of them were given either 1,200 international units per day of vitamin D3, or they were given placebo. And the endpoint was looking for influenza A by doing nasal swab antigen testing. And what they found over a winter season was that those subjects that got the supplemental vitamin D only had a 10.8% prevalence of influenza A, whereas those that got placebo had an 18.6% incidence of influenza A. And the absolute risk reduction, simply the difference between those two, was 7.8, which translates into a number needed to treat of 13. That's a pretty darn low number.
The number needed to treat takes basically the total number of people and people that benefited from it, and calculates how many people will you need to treat to see one person succeed in treatment. There's number needed to treat and number needed to harm, and we look at those and find, is this drug worth it? Is this medicine worth it? Is this procedure worth it? The number needed to treat is 13, so a low number to treat is actually pretty good. If you treat 1,000 kids and divide that by 13, you get the number of how many are going to be successful. That's a really good number to treat. The higher the number, the less likely you're probably going to do it, especially if there's serious side effects. Harm the patient.
Number, which means that this intervention is pretty powerful. And you can see here the other related indices here showing that it was statistically significant. So clearly here, vitamin D supplementation in school children. These are children that would not normally necessarily be at risk for having vitamin D deficiency. But even in this population, it was able to reduce the incidence of influenza A. Okay, so let's talk about COVID itself. And what we started to find out early on in COVID-19, when we started to research this, is some uncanny similarities between what COVID-19 looked like from a biochemical standpoint and what vitamin D deficiency looks like from a biochemical standpoint. Now, this doesn't prove anything, but it certainly raises your eyebrows and you start to look a little bit closer, because what we saw was that in both conditions, IL-6 was elevated. Tumor necrosis factor alpha was elevated. Gamma interferon was elevated in vitamin D deficiency and also in COVID-19 late in the course.
So IL-6, just say that? It was hot. IL-6 was neutrophils, I think? He said that, I don't know.
Th1 adaptive response was also elevated late in the course of COVID-19.
So interferon gamma, or INF, we use that to treat a lot of viral infections. Interferon you'll hear with hepatitis disease, hepatitis C. Hepatitis C is a RNA virus, or picorna, or it's a virus. But we use interferon gamma, and what that does is hypes up the T cells. And T cells, they basically go to your cell and they go to the target and kill it in person. Whereas your B cells, they use antibodies and nets and stuff. So they're less personal, where the T cell's kind of up in your face. Because if it sees a cell infected, it's like, sorry, you got to die. So what this is saying, it's saying interferon gamma is seen late in COVID-19, but it's also seen in vitamin D deficiency. The Th1 is we have two types of T cells. You have helper T cells and killer T cells. And Th1 is a killer T cell response. Normally you see with viruses. You see the Th2 response when you're helper T cells, when you're making ACE2. ACE is angiotensin converting enzyme 2. That receptor is important when we control blood pressure or constriction of blood vessels. There's a high prevalence of ACE receptors, as you would guess, in our lungs. That's why when a lot of people get on a drug called lisinopril, they get a dry cough, and that's because we're inhibiting expression of angiotensin and increasing bradykinin, which causes a dry cough. So we're seeing the expression of that go down, which means it's being stimulated too much for some reason. If you overstimulate something, you press it less because you need to counterbalance it. And then we're seeing increased coagulability. So I was actually going to talk about this today. I saw a lady, a Latina lady, that had severe gangrene of her fingers after she got COVID. And there's only a few things that cause that, and one is blood clots to the extremities, disseminated intervascular clotting. Disseminated meaning everywhere, vascular blood cell vessels. So basically, all your clotting factors are the stuff that makes you have a blood clot start going at the same time. You get all these clots and you clot off and everything dies, and then you run out and you bleed everywhere and die. So that's kind of scary when it comes to COVID, because young people are blood poisoning. So basically what it's saying is all the bad signs of COVID are all similar to all the bad signs that come with, or all associated with, decrease in vitamin D. So it's an increase in the deficiency.
We see both ACE2 expression reduced in both conditions and a hypercoagulability in both. And so that gave us pause and started to see, well, maybe vitamin D may play a role in COVID-19.
Would you expect vitamin D deficiency to also mirror other viral infections, or is this something unique to COVID-19?
No, I think it could also mirror other types of infections. We see this during this time of year. We see increases in coronaviruses in general, rhinoviruses. We also see it in influenza. The one thing that we don't see in those other viruses, however, Kyle, that we do see in COVID-19 is this hypercoagulable state. It's not as pronounced as we're seeing it in COVID-19. There was a recent article that was published in the New England Journal of Medicine, actually not recent, it's been a couple of months now, that showed that in autopsies in patients with COVID-19 compared to those who did not have COVID-19, there was a 9-fold increase in blood clots in the lung tissue. So that is something that is very unique. A couple of months now.
And then when we started to look at the epidemiology of patients with COVID-19, again, more eyebrows being raised. Here's a pretty powerful study looking at 17 million patients, specifically looking at about 10,000 COVID-19 deaths. And what did we see? We see something really interesting. If you look here at the age group, this is nothing new. We know this, that those who are higher in age are more likely to die from COVID-19. And you can see here, the higher in age we go, the more risk there is in that category. We can see that male gender has some risk as well. Here we see with obesity that as the obesity level goes up, the risk starts to go up as well. And here we see again with ethnicity, as we start to compare to Caucasian or white, that all of these darker skinned races have increased risk for death in COVID-19. And if you will remember, these are exactly the same 3 things that we saw put people at risk for vitamin D deficiency: both elderly age, increased obesity, and darker skin color. And so one has to wonder now, is this coincidental? Or is this something else that we need to investigate? Is it possible that vitamin D may have a role in the mortality and morbidity of COVID-19?
So that was a great chart that you just showed about different patient characteristics and hazard ratios associated with those patient characteristics.
I mean, if you look at it, and everything that heard about it through media and not through science has kind of followed that trend. And this is showing, and this is for a while now, we've known there's this correlation there between vitamin D and mortality of these viral infections, especially lung ones, and the prevalence of vitamin D deficiency in certain age populations. The older you get, the less you make of stuff. The more obese you get, the more you hide your vitamin D from your body. And the darker skinned you are, the less vitamin D you have, which would kind of not make sense, right? We would think the more darker you are, the more you're exposed to the sun, but that's not necessarily the case. Your melanin is your melanin. You're going to have that genetically, whether you're tanning or not. And there's a lot of countries where dark skin is not the favorite. So people stay out of the sun a lot and want to have lighter skin. So that may attribute to that. There's also, you have kidney disease. Getting that activated vitamin D, that last step is 25 hydroxylase be converted into 25-1 hydroxylase. And if you can't convert that 1, then you don't have active vitamin D, and therefore you don't have any of the benefits. It says it's a steroid hormone, and it's basically controlling the way our body makes its proteins and lives and works. And if we can't do that in our lungs, then we're going to have, our lungs won't be able to clear infection, or we're not going to be able to express in immune cells the right chemicals to fight off disease.
Data, but what's your thought on this? How can you explain that?
Oh, no, I don't think it should make you question at all. You know, early on, we felt that it was the patients with lung disease that were going to be the ones that were ending up in the hospital. But clearly that's not the case. The type of people that we're seeing that are having severe reactions from COVID are the ones with cardiovascular disease. This is a vascular inflammatory condition, not one that necessarily hurts the lung from a respiratory standpoint. There's several explanations for this.
Which people do not receive sufficient sunlight to retain adequate vitamin D levels during the winter. This suggests a possible role for vitamin D in determining outcomes for COVID-19. There are similar. So again, mean vitamin D levels that were very high had almost 0% mortality, whereas those that
okay, so this is showing on the y-axis how many people die per million population, and on the right side is percent deficient, or percent levels are mean higher to the right, the more vitamin D you have. You can look, the farther you go to the left, the less vitamin D, the higher the death is. So we have this linear regression plot, and that's kind of actually, they probably skewed the data to get this linear. It's not such a, but there is a correlation there, linear correlation to low vitamin D and higher mortality. Actually change vitamin D. The problem with vitamin D is it is fat soluble. So anything fat soluble you can overdose on. Vitamin C, if you take, a whole jar of vitamin C, you're gonna have horrible diarrhea, but you're gonna pee it all and poop it all out. Vitamin E, on the other hand, is very toxic because it's stored in our fat. So this doesn't mean go home and just start eating a bottle of vitamin D that you have in your counter, because that's not good. But it's saying that more people may need to supplement, start looking at levels. If you have kidney disease, liver disease, or don't get out in the sun a lot, maybe at higher risk.
that were very low, like around 40 to 50 in this situation, had a higher mean COVID-19 mortality per 1 million population. Of a letter to the editor titled Vitamin D Deficiency in COVID-19, Mixing Up Cause and Consequence. And what they were able to show here in about 9 subjects when they gave lipopolysaccharide to healthy volunteers, which is another way of inducing the immune system, is that they found that plasma vitamin D levels did in fact drop slightly. And if you look here at the scale, it was on the order of maybe about 5 points. They were able to show that when somebody has an infection or is undergoing an immune response, their vitamin D levels can drop. And so it is possible.
That makes sense. If the immune cells use vitamin D, they're going to suck that up out of the blood. So that might be why they're lower, because we're using.
But this is a modest drop here, something that we ought to keep in mind as we go forward. Now, of course, the SARS-CoV-2 infection may cause a vitamin D level to go down, but only after you've been infected. What about those people that have had vitamin D levels checked well prior to them getting an infection? Well, here's a study that looked at low plasma 25-hydroxy vitamin D levels as an associated risk of increased COVID-19 infection. And what they showed here, they took 14,000 subjects with at least one test for COVID-19 and a previous vitamin D. And what they found was that they had to exclude about 6,000 of them because they did not have a former vitamin D level. And so 7,800 of them had a test for COVID-19 and had a vitamin D level on record. And they were able to show that about 10% of these patients had positive COVID-19 tests and about 90% did not. So what did they show? Here they divided levels of vitamin D at around 30. And so these are the people that were low here on the left, and these are the people here that were normal. Notice that there was a big gap here.
Just reading through this real fast. Basically, it's showing low vitamin D, and the older you are, both of those increase your mortality. So seems like everything that we're kind of going through is showing vitamin D is fairly important. This is again showing lower vitamin D, increased positivity rates. They're even saying not even getting COVID-19, but just being positive with SARS-CoV-2, which is the virus. And I want to make a point to that. When you get tested and you test positive, you are not testing positive for COVID-19. COVID-19 is similar. I'm going to use this analogy because people can relate better to it. HIV and AIDS. So HIV is the virus. AIDS is the disease you get that you die from because of the virus. So SARS-CoV-2 is like HIV, and COVID-19 is like AIDS. So people say I've had COVID-19 and I wasn't sick. Well, that's technically impossible because you can only be COVID-19 positive if you only have COVID-19 if you're otherwise you're SARS-CoV-2 positive without symptoms. So what this is saying is that it also stops you testing positive, or at least that's what it seems. This graph is kind of skewed from 0 to 20%. So that's
higher rates of SARS-CoV-2 in the northern region of the United States above the 35th parallel, whereas in the central and southern states it was relatively low. But the relationship still existed. This also existed in terms of race. So it didn't matter what race you were. If you had lower vitamin D levels, you had an increased risk of SARS-CoV-2 positivity. But again, the darker skinned races had a higher risk of SARS-CoV-2 positivity with respect to the white baseline here in this case. In terms of age, again, it
People in the middle, and I would say
reduces the vitamin D level. And we've shown that that's the case, acutely at least, but not necessarily chronically. It could be that there's another factor that's causing both a susceptibility to SARS-CoV-2 infection and also a vitamin D level. And so if you just change the vitamin D level, that won't metabolize. It's ready for the 1-hydroxylase enzyme to activate it and for it to be used. So it kind of speeds up the...
So this is where immunocompromised people have a problem with fighting off infection. Yes, they're not able to activate vitamin D.
Group, 50% of those went to the intensive care unit. Now, something you should understand is that they hadn't, and when they looked at that, there was a statistical significant difference, as you can see here, P of 0.002. Well, here was another study group in those that got vitamin D.
Let's get the conclusion.
55,000 international per milliliter. And that data, that supplementation, healthy volunteers. In relation to this study, they took
this is about dosing your vitamin D
and looked at vitamin D levels. And there was a wide range of vitamin D levels in this population, anywhere from 4 nanograms per milliliter to 158 nanograms per milliliter. And people were supplementing anywhere from nothing to 55,000 international units a day. And what they found was pretty interesting. They found that early on, supplementation per 1,000 international units brought up people's levels pretty quickly. But then as the amount of supplementation started to go up, the levels started to go up more slowly, such that in the first 1,000 units that you take as a supplement, each 1,000 units would increase the level in your blood by 4.8 nanograms per milliliter. But if you got up to the 10,000 range or the 50,000 range even, 15,000 to 20,000 range, 1,000 units would only raise it up by about a tenth of that, or 0.4 nanograms per milliliter. So in other words, down here, 1,000 international units when taking a low amount would raise your level by 4.8 nanograms per milliliter.
Wealth curve.
But if you're already taking a large amount, each additional increase by 1,000 international units would only raise it by about a tenth of the to get them up to a regular level than would be expected if they were overweight or obese. In fact, their recommendations is that for people who are overweight, they should take 1.5 times what is normally recommended to get their vitamin D levels up. And for those that are obese, have a BMI of greater than 30, it actually is 3.0 times as much. And that might be related to the fact that vitamin D, of course, is fat soluble. So there are a lot of things to take into consideration, and this is a moving target. Also take under consideration the fact that currently we are moving into winter months. But again, these all need to be parsed with the season and weight and age and all of those sorts of things that we talked about.
So probably the more obese you are, the more you should take.
Vitamin D in Germany, I'm sure it's not very dense with COVID-19. Please share this with as many of your loved ones as possible, because I think this could potentially be beneficial in our fight against COVID-19. And for more information, visit.
So I think after looking to that and trusting this guy, pretty much got me through. Just he has a very solid understanding. It's really opened my eyes to the importance of this. Just showing where all of this data and all these studies have that same correlation, in that no matter what subset you look at and you count out the bias, that vitamin D has some role in protecting your body against this infection, and not only infection, but saw it in flu, and SARS-CoV-2, which is pneumonia for all intents and purposes. That's what it is. And so the older you are, the more overweight you are, and the darker your skin, those three things will increase your chances of getting sick and having a worse off time with this virus. So what can you change? Can you change your age? No. Change your weight a little bit. Can you change the color of your skin? Not so much. So the weight thing is something to work on, but supplementing the vitamin D is a faster way to do that. So it said, if you're overweight, you do your BMI and it says overweight, you would take 1.5 times normal dosing. And if you're obese, it's 3 times. And it's good to check this number because you may feel like you're not in one of these categories. But according to the doctors and scientists, maybe. I was shocked when I looked at the time. So do that. But like I said, that's something you talk with your healthcare provider about because, somebody that's 100 pounds obese and somebody that's 400 pounds obese, they're not going to take 3 times, both of them. Probably going to incrementally. I don't think a lot of physicians know how to dose this correctly, since I'm all just learning about it. But use a called UpToDate, like Google for doctors, and it's filled with evidence-based, all the evidence-based medicine. Dosing is on. So I think this is actually pretty solid, and I would go with it and actually recommend people talk to their doctor about supplementing vitamin D, getting it checked, and seeing what they need to do, especially during this, because even the vaccine, most of you aren't healthcare providers, so you're not going to get this vaccine until about 4 months from now. So whether you want to take it or not, you really don't have a choice. And then when you do take it, it's not ever showing that it prevents against contacting this virus. So it's not going to shut down lockdown. It just stops you from getting sick from it, 95%. Good. It doesn't stop the spread of it. And what seems to be working is vitamin D in these cases. Lowers the positive test results as well as severity of infections and ICU stays. So if we can monitor that, and that makes sense. We call it vitamin D. We think it's simple, but like I said in the very beginning, works like a steroid. It affects our DNA. It just floats through your cell. I mean, that's why we use steroid creams. You can get through the tough skin of your hands. You can get through anywhere and have a really fast effect. And then it causes a very important effect, which is pulling your DNA. So obviously, there's got to be more than just calcium. I think I had some other stuff, but I don't think I want to put this out there. Even more so now after I watched it with you guys. I watched like 5 minutes of it before, and I was like, oh, this is good. And then now I'm kind of like, if you want to check it out, just go to YouTube and type in MEDCRAM. Like I said, his lectures are designed toward people that are pre-med or medical school. But, all you have to do is have a want to learn. You have to be in medical school. Like I said, I learned all this outside of my classroom. Helped me with school. So if you want to know more, everything's available. I posted the link in the description for his channel. If you get it, just come back there. I'll post. I was going to cover antibodies and their function, how we can't really wait on an immune response. Might do that some other time. Basically, long story short, is even after you're exposed to the virus, your body takes weeks to make the good antibodies. It has to do genetic remodeling, so it switches your DNA around, creates a new DNA in those cells, and then after that, it tests it to make sure which one's the strongest, and then it makes it. So you can have up to 2-3 weeks before you have a new decent antibody response. Any virus, bacteria. We can cover that later. But right now, I think the take-home point is vitamin D is important. So if you're old, dark, and overweight, vitamin D should be checked and treated. It's a expensive medication. Right. That'll be it. Cover. If I think of it, I'll do it. I don't know. And that screen reminded me is like, we're all going through shitty times. Virus has affected everybody's lives, whether directly or indirectly, whether it's directly affected you or somebody you love and affecting them affects you, interact with them. I try to seek comfort, and the whole world is kind of going through some times. But the only thing that we have control over is actions and what we do, and I've learned that actions are a thought process, and intentionally doing something every day, whatever it is, if you're intentionally doing it, you schedule to do it, and it helps our brain out. So, I like to say, just do something better today than you did yesterday. It doesn't have to be big. Just I think if we start doing that, take my own advice. If you have any questions, if you have any hate, just for me, because I'm vaccinate your kids.